So now with polycystic kidney disease, it's a systemic disease. It affects multiple organs outside of the kidney, particularly polycystic liver, so multiple liver cysts. But another major extrarenal manifestation that's associated with AD-PKD is intracranial aneurysm, which is the topic of our article. My name is Fouad Shabib. I'm one of the nephrologists at Mayo Clinic in Jacksonville, Florida. I'm an expert and specialist in polycystic kidney disease, and it's my pleasure today to talk to you about our upcoming article and manuscript at the Mayo Clinic Proceedings entitled Intracranial Aneurysms in Autosomal Dominant Polycystic Kidney Disease, a Practical Approach to Screening and Management. This will be coming up in the June 2025 issue. So AD-PKD, or autosomal dominant polycystic kidney disease, is the most common inherited kidney disease. Now, this disease leads to multiple kidney cysts and eventually to kidney failure. It does have a high phenotypic variability, so some patients reach kidney failure in their 30s, 40s, but some reach later on in their 70s and 80s. On average, we think PKD leads to kidney failure by age 60 for 50% of patients. So PKD patients would have higher chance of having intracranial aneurysms. So as a general population, we think all of us as general population without any diseases, if we assume we have no diseases, would be 3% of patients would have some sort of aneurysm that is asymptomatic. Now in PKD patients, if we take all AD-PKD patients, it's about 7 to 8% of this population will have intracranial aneurysms. And there's few risk factors that would increase the chances for PKD patients to have an intracranial aneurysm. The main important one is having another family member with PKD and with intracranial aneurysms. Then their chances go up all the way to 20, 22%. So it becomes very important to make sure that we screen and we know if our patients have intracranial aneurysms in order to prevent any potential bleed from these aneurysms. Which leads to subarachnoid hemorrhage and very high morbidity and mortality. An aneurysm is when there's a little bit of a weakening of the blood vessel and then there's kind of a pouch or a bubble. And because the system is pressurized, so there's blood flow going, then it becomes kind of a bubble. Now, this bubble can grow and rupture. If it ruptures, there's the intracranial bleeding or subarachnoid hemorrhage, and that's kind of a really big event for our patients. There's a lot of symptoms that comes with that, and the majority of these aneurysms are in the anterior circulation. So you can see in the figure that there's more intracranial aneurysms in that section. Typically, it's at a bifurcation of the blood vessels. Now, thankfully, anterior intracranial aneurysms are a little bit less risky to rupture, so we think posterior aneurysms are at more risk for rupture. Other risk factors that could be kind of associated with an increased risk is just being a female. It's a little bit at high risk. Also, with older age, we tend to develop more aneurysms. Then also hypertension and smoking as kind of a general risk factors for intracranial aneurysms. There's also, in the general population, having an ancestry as a Japanese or Finnish ancestry puts our patients at a little bit high risk, but that's kind of a general risk factor, not only for PKD patients. So for us at Mayo Clinic, a multidisciplinary approach is the way to go, as well as a shared decision-making with our patients. So we explain to our patients what's the current situation for them. We individualize the approach, so kind of tell them exactly what their risk factor is. So definitely there's benefits to screening. The main benefit of screening is to prevent the rupture, right? So if we find an aneurysm that's a little bit larger in size or it's growing in size with the follow-up, we can go in as a team, either our neurosurgeons or neurointerventional radiologists would go in and do some sort of intervention to block the blood flow to this kind of bubble or pouch, so it doesn't burst and cause the bleeding. In some situations, it could be reassuring that if we don't find the aneurysm, a few times we would see an aneurysm during the screening that's quite big, let's say 7 millimeters, 8 millimeters, and right away we would go in and intervene. And I think in these situations, I think it's life-saving to go through these procedures. Now, the downside of of kind of screening would be if we find the aneurysm, it can cause anxiety to our patients. So we definitely, before we screen, we kind of explain what are the possible outcomes of this screening, and then if we find these aneurysms, what does it mean, and how we follow up with imaging. And then otherwise, other limitations for screening, sometimes patients could lose insurance or could have limitation on their occupation or their work. So we discuss all these during that discussion. If it's a big aneurysm, we'll go right away for an intervention. If it's a smaller aneurysm, again, we favor a multidisciplinary approach, so we refer our patients to our neurology colleagues as well as neurosurgery colleagues. Most of the times, it would be just a serial MRA, so just another test to check if the aneurysm has grown. So we do that in 6 months after we identify the first time that aneurysm. Then we repeat in another year and then yearly thereafter. But we'll need to repeat an MRA, another screen at a certain interval. There's no consensus on the interval. We think if someone is at high risk, then we would do every 5 years. If someone is at a general risk of PKD, we would say 5 to 10 years. In rare situations or in some situations where there's subarachnoid hemorrhage, the patients would have a very distinct and severe symptom, which is the thunderclap headache. We think that's equivalent to kind of when the aneurysm has bled, so that's the subarachnoid hemorrhage. The symptom would be the worst headache of their life. It kind of peaks within a minute. It's associated with nausea, vomiting, confusion, other symptoms. It could be kind of neurological symptoms. In these situations, it means an immediate visit to the emergency department. So we educate our patients and their caregivers that if that happens in that rare instance, then they should be aware that this is really a big emergency. We don't think that general headaches are kind of due to aneurysms, but if there's any change in the features of headaches, it's reasonable to be evaluated and be checked. So this is kind of the general overview. Again, we provide that kind of algorithm or the practical approach for screening and how to manage that. I think this is important to make it relatively simple or practical for our practicing nephrologists, as well as general internists, as well as anyone who takes care of PKD patients, is to make sure that we have that discussion about the risk of intracranial aneurysm and when to screen. One last thing that we didn't mention is also we recommend screening before any major surgery, like a kidney transplant or maybe a liver surgery. Sometimes our patients need a partial liver resection. So before any major surgery, we recommend to obtain a brain MRA or screening for an aneurysm. Also, if someone has an occupation that could affect many other lives, such as a pilot or bus driver or any other occupation, then also it's recommended to do these screenings. So this is in a nutshell. This hopefully will help the clinical practice in a way that it becomes, again, a practical approach to screening for aneurysms, and easier to kind of have that discussion and decision, as well as the follow-up with our patients. Of course, there's more research that is needed in this area to understand, as there's particular mutations or pathogenic variants in PKD that causes these aneurysms. So there are some group within the PKD space, researchers that are looking into that. So the more information our patients provide, the more genetic testing, the more imaging and data together that we kind of consolidate under consortiums or international registries, it is very helpful for our research in order to continue to understand this disease and help the practice on a daily basis.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings. or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.